Hello, everybody out there. I'm Bob Willard. I am with the Knee Institute and Regenerative Medicine. And today's topic is going to be knee pain and osteoarthritis and the options of how we can overcome those difficulties. But I do want to put a little reminder out there that many of you are probably not familiar with. The next show we do is going to be a little bit unique and different. We're going to be interviewing several people, and the topic is going to be how chronic pain and immobility affect the family life. In other words, the husband may have this difficulty, but how does it affect his wife when he's in tremendous amount of pain? He can't get around, he can't sleep. We're going to bring some guests on that have been in that situation, and then we're going to have them discuss how they've overcome that and how their life has changed. It's not something that we normally think about or talk about, but it does have a major impact in our lifestyle. But today we want to talk about knee pain, and probably the biggest culprit of knee pain is osteoarthritis, okay? And we're going to talk about viscosupplementation. So let's first talk about symptoms. Symptoms of those who have knee pain and osteoarthritis. And I'm sure there's many of you out there that wake up in the morning with stiff knees and legs, and when you get out of that bed, it's really hard to stand up. We also see people that have pain going up and down the stairs, and many times when they're going down the stairs, it's even more difficult. And you will see them holding onto the railings and actually walking sideways, one step at a time there. And you'll see others out there that they try to handle this themselves, and they'll take aspirin or ibuprofen or other medications, including prescription meds, okay? And I'm sure there's a lot of us out there, me included, there. And probably one of the most difficult things for me was that it will affect any of your activities that you enjoy, and it makes it very difficult on your mobility and the pain, and then you don't have the same quality of life that you had. And that's not a good place to be, but we have all that have had knee pain experienced that. And we also experience, a majority of us, having problems sleeping, primarily because of the pain and the discomfort, okay? And we also have difficulty getting out of the chair. And that was one of the things that was very difficult for me when I had the osteoarthritis. I virtually couldn't get out of a chair. And what was really the eye-opener for me is that my spouse and I went to Jamaica for a trip, and the plane landed, and she was on the window side, and I was in the middle, and there was another individual on the other side of me. And everybody started fighting for their luggage and wanting to get out and get into the warm, fresh air and enjoy the beginnings of their vacation or holiday. My problem was I was having difficulty getting out. And so finally I asked my spouse if she could just crawl over me and get over, and then I would make an attempt to get out. So I grabbed the hold of both armrests that is available, and I pushed as hard as I could and got myself up into a standing position and was able to get out. What was even more frustrating is I looked up and I was the only one on the plane except for a couple of stewardesses and a pilot. It was very embarrassing and very frustrating. So as we headed down to get our luggage, I looked at her and I said, I cannot live the rest of my life without immobility. I'll find a way to deal with the pain, but I will not give up my mobility. I want to get around. I have a 6-year-old granddaughter. I want to play with her. I want to throw a ball with her. I want to run with her. I want to be in the park with her. I'm a very active and guy. I still participate in the Masters swim there, so I'm very competitive. But if you can't do those things, it's just very frustrating. Not only do you go through periods of anger, but you really just get down and depressed. And so those are some things. Also, just the simple task of walking becomes difficult. And the other thing is you look down, and many of us have edema, which is really just a simple swelling in that area there. And lots of us, including me, have been told that I needed to get surgery. So when we we came back from the vacation. I said, there's got to be another way. There just has to be another way. And we'll get into the other way in just a little bit. But what we probably should do is define what's osteoarthritis. And if we go in the medical dictionary, and I wrote this down, so I want to quote it, is arthritis is characterized by erosion of articular cartilage and loss of synovial fluid. So what that means, if we can imagine these are the two leg bones, and out here is the patella, which is the kneecap. So we have this here, there. Now, under normal circumstances, there would be a padding in there, and it's called cartilage, and I'm sure we've all heard of that. And then in between the cartilage is lubrication, and it's called synovial fluid. Well, what's interesting, as we age, we start to lose that. And so less and less of the synovial fluid we have, or from trauma. But the majority of this is just through aging, okay? So eventually what happens is there is no synovial fluid, if we get to that point, and the cartilage or the pads in there dry up, and then we no longer have this ability to have a padding there so we don't feel anything, and then it comes to bone and bone. And I'm sure we have all heard we're bone on bone. Okay, and if in fact we're bone on bone, what happens is it's extremely painful and we can't hardly move. So let's sort of just compare this to a shock absorber in our car. Okay, when the shock absorber no longer has any lubricant or padding in there, we go up and down in the car and we bounce everywhere, and it's not a very pleasant experience. So we put a new shock absorber in there, it doesn't go up and down. It absorbs it. Okay, and it's just sort of the same thing with the knee joint and all the other musculoskeletal joints. But today we're just talking about knees. So how do we solve that problem? Well, first of all, we have to decide if it's bone on bone. How do we do that? Okay. Many patients will tell you that a physician's told them, or a nurse has told them, or a physical therapist told them they're bone on bone. Unless we have some kind of imaging, we don't really know. And if somebody can look at my knee and touch my knee and tell me I'm bone on bone, I always kid them. I tell them, I want to touch you because my goal in life is to be with God, and you must be God, if you can see, or Superman. Okay? So the reality is we either have to go for an x-ray, which is a very good tool to see if we're actually bone on bone, or to get in more depth and more detail, we would get an MRI, okay? It just depends on the situation. What we're looking for in this is to see if we can get any space at all between those two bones. And it doesn't have to be very much, okay? This is great where it should be, and this is still makes it available so that we can actually have a treatment plan and get back to where we were before, okay? So how do we do that? How do we do that? Okay, well, generally, when you see treatment of arthritis, is you will be directed to a physical therapist, and they will do regular physical therapy. And what that means is they'll put a hot pack on it, and it'll feel real comfortable, and it feels good. The problem with that is, an hour later, the feel good isn't there anymore. Okay, there, or they'll put what's called ultrasound, and I'm sure many of you have had this. They put some ointment on the area, and they have like a little wand here, and they spread it around and with the ultrasound gel, and that does give you some relief, but it doesn't give you permanent relief. It's just temporary. You'll see other people that'll put you in a brace or a sleeve like the ones you see on TV, Tommy Copper, there, and it helps a little bit, but it really doesn't solve the problem there. Or the physicians will give what they call viscosupplementation, which is where they actually inject into the knee, they inject hyaluronic, okay, and that acts as the lubricant. Now, more often than not, the physicians get only about 30% success. And the reason for that is that's, first of all, they don't use guided imagery when they put it in. So they just put their thumb on your knee and say, oh, that's where it is. I've been doing this for 25 years. I know exactly where I'm going. But they can't see where they're going. They don't know where it is. So what's more important is if you are going to get something like that, you want whomever is doing it, they have guided real-time imagery. And the best way to do that is what's called fluoroscopy. So it's a pretty expensive piece of equipment, and that's why a lot of people don't utilize it. But when the physician or the nurse is putting that injection in, they have a screen, and they look at the screen, and it will tell them exactly where they are. So they might put the needle in, and it might be a little bit over here instead of here. So they can make adjustments in real time, so they get it in the real space. And as I mentioned before, as long as there's a little bit of space, we can get that in there. And then that lubricant starts to take place, and you don't have that feeling of bone to bone, and you don't have that pain, okay? And it works pretty effective. And that's what some of the doctors are doing, that's all they'll do. Or they'll send you to physical therapy for the normal, regular physical therapy. The problem with that is there's no controls on that. They have no idea of what they're doing in that physical therapy department or place that you should pick. You choose that on your own choosing. And so they have no idea what's going on there, so there's no controls there. So that's really important. The other thing some will do is they'll give you a brace, but bracing helps a little bit, but it doesn't solve the problem. And the biggest reason for bracing is just to bring some stability. And one of the problems that a lot of patients do is they will wear that brace almost 24 hours. Now what happens with that is it becomes a crutch, but more importantly, they become dependent on it, okay? And then they wear it all the time. And then it doesn't utilize the function that it was originally designed to do. So you don't want to be wearing that brace 24 hours a day there. Or you may have the option, somebody will give you some home exercises. All of those things are good, but they will not get the results that you're looking for in most cases by themselves.